Hello all, welcome to a short tutorial on the topic anti-Parkinson's drugs. So, what is Parkinson's disease? It is a progressive neurodegenerative disorder, and it is first described by Sir James Parkinson. That's why the name Parkinson, and it is actually characterized by condition. The clinical manifestations are TRAP, that is tremor, rigidity, and akinesia, which means reduced or absence of movements, and then postural instability. These are the clinical presentations of the disease, Parkinson's disease, and the disease occurs due to degeneration of the dopaminergic neurons in substantia nigra pars compacta. So this is a part of basal ganglia, and in this condition there is a degeneration of neurons in substantia nigra pars compacta, and that leads to decreased release of dopamine in the striatum. Okay, and there is an imbalance between dopamine and acetylcholine level. The level of dopamine in the striatum decreases, and there is a relative increase in the acetylcholine levels. So this is normally in brain there is a balance between dopamine and acetylcholine, and in Parkinson's disease level of dopamine decreases, and there is a relative increase in the acetylcholine activity. This is the major part of physiology behind Parkinson's disease. Okay. The normal function of dopamine is actually it stimulates the motor activity of the cortex, and decrease in the dopamine level causes reduced cortical motor activity that leads to bradykinesia, and relative increase in the acetylcholine level leads to tremors. Okay, and there are dopamine actually stimulates the motor cortex by direct pathway and indirect pathway, which occurs in basal ganglia, and basal ganglia this stimulates the thalamus, which then in turn stimulates the cortex. Okay, and in Parkinson's disease this stimulation of the cortex is reduced, so that causes bradykinesia, and relative increase in acetylcholine level causes tremors. And these are the clinical features. You can remember it as TRAP, that is tremor, rigidity, akinesia or bradykinesia, that is slowness of movement, and postural instability, which is a late feature. So the classification of anti-Parkinsonian drugs, and we can manage Parkinsonism by either increasing the dopamine transmission or by decreasing the cholinergic activity. Okay, so which are the drugs that influence the dopaminergic system? First is dopamine precursor. That is levodopa. Okay, it is a precursor of dopamine, and it crosses the blood-brain barrier and get converted into dopamine, and thus increases the dopamine levels. Next is dopamine agonist. Okay, these drugs bind to the dopamine receptor and stimulate those receptors. So it has dopamine-like action, not precursors of dopamine. They stimulate the dopamine receptors. Those include Bromocriptine, Pramipexole, and Propinerol. These are the main drugs. Also, other drugs are rotigotine and apomorphine. Okay, so dopamine agonists are Bromocriptine, Pramipexole, Propinerol, rotigotine, and apomorphine. Next is NMDA receptor antagonist. NMDA receptor antagonist. Okay, these actually reduces the glutamate transmission, and also they increases the dopamine levels, dopamine release. They increases dopamine release and decreases the glutamate transmission. And decreasing the glutamate transmission actually decreases the indirect pathway in the basal ganglia, and this also stimulates the cortex. So the drug is Amantadine. Okay, Amantadine. This is the NMDA receptor antagonist. Next group of drug is monoamine oxidase inhibitor, MAO inhibitor. Okay, actually MAO is the enzyme. Monoamine oxidase is the enzyme that metabolizes the dopamine, and the inhibitor MAO inhibitor actually decreases the metabolism of dopamine and increases the dopamine levels. Okay, those include Selegiline, then Rasagiline. Okay, the next group of drug is COMT inhibitors. They also decreases the metabolism of levodopa, and they include the tolcapone and entacapone. Then next include these are the drugs which increases the dopaminergic activity. Okay, so these are the drugs which increases the dopaminergic activity. Next, which are the drugs that decreases the acetylcholine levels in brain? So those include centrally acting anticholinergics. Okay, we don't need peripheral anticholinergic activity, we only need centrally acting. Okay, those include benztropine, benzhexol, it is also called trihexyphenidyl, and also bipyridine. Okay, these are the centrally acting anticholinergics. Now, antihistaminic drugs with the anticholinergic activity are also there. Okay, antihistaminic, that is H1 receptor blockers with the anticholinergic activity. Those include promethazine and diphenhydramine. Okay, so these are the main Parkinson drugs, anti-Parkinsonian drugs. Now, first of all, levodopa. So what is levodopa? It is a dopamine precursor, and levodopa is the most effective drug for Parkinson's disease. So it is the most efficacious drug, and it is a precursor of dopamine. And why we are not giving dopamine directly, and we are giving a precursor of dopamine? Because dopamine cannot cross the blood-brain barrier. So we are giving levodopa, which can cross the blood-brain barrier. It crosses the blood-brain barrier and gets converted into dopamine in the CNS. So that's why we are giving levodopa, and it crosses blood-brain barrier via the amino acid transporter. So, and also it is absorbed from the intestine also by amino acid transporter. So that has a significance that we will discuss, and it is converted into dopamine by the dopa decarboxylase enzyme. Okay, and why carbidopa is given? Okay, levodopa is never given alone. We always give levodopa along with carbidopa. Okay, levodopa along with carbidopa. Why? Because if levodopa gets converted into dopamine in the periphery, that can cause peripheral side effects. Okay, it can cause peripheral side effects, and also that decreases the availability in CNS, availability of levodopa in CNS. So if we inhibit the peripheral conversion of levodopa by inhibiting the peripheral dopa decarboxylase, we can decreases the peripheral conversion of levodopa, and that reduces the peripheral side effects like nausea, vomiting, and also hypotension, and increases the availability of levodopa in brain. So levodopa is always given along with carbidopa. And the pharmacokinetics of levodopa, it is actually orally administered drug, and absorption is reduced by high protein diet, because I already told you that levodopa is absorbed from intestine by amino acid transporter. So there is a competition between levodopa and proteins in absorption. So high protein diet reduces the absorption of levodopa. So it should be given 30 to 60 minutes before meal. Okay, 30 to 60 minutes before meal, not after. Before meal it should be given. And also the levodopa has short half-life, about 1 to 2 hours, and it is metabolized by dopa decarboxylase and COMT. Okay, so which is the dopa decarboxylase? Which drug reduces the metabolism of levodopa by dopa decarboxylase? It is carbidopa. And we'll also discuss about COMT later. COMT inhibitors, which are Entacapone and Tolcapone. Okay, we'll discuss it later. So what are the side effects of levodopa? So side effects can be peripheral side effects that can be reduced by administering carbidopa along with it. Peripheral side effects include nausea, vomiting, then postural hypertension. Actually, dopamine can causes vasodilatation. Okay, so if we give levodopa, that can lead to vasodilatation and cause postural hypertension. Then it can also cause cardiac arrhythmias, tachycardia, palpitation. Then has central side effects which include dyskinesia. Okay, dyskinesia. What is it? These are involuntary movements. Okay, abnormal involuntary movements that include tremors, chorea, dystonia, and other CNS side effects are hallucination, confusion, then insomnia, and there are also long-term complications of levodopa. So long-term complication. These are not side effects. These are long-term effects of using levodopa. Okay, long-term effects that include wearing off phenomenon or end of dose deterioration. Okay, what is wearing off phenomenon? Actually, wearing off phenomenon is due to decrease in the plasma concentration of levodopa towards an end of a dose interval. Okay, at the end of dose interval, the plasma concentration of levodopa decreases. So the effect of levodopa decreases. Okay, that is wearing off phenomenon. And this can be prevented by administering levodopa in smaller but more frequent doses. Okay, we can give it as smaller doses but more frequent. Then on and off phenomenon is there, that is this occurs after long-term use of levodopa. Okay, both of these. And on and off phenomenon is that sometimes there is loss of effect of levodopa, that is off phenomenon, loss of effect of levodopa, and sometimes all the effects are shown but with the disabling dyskinesias. Okay, disabling dyskinesias, that is on phenomenon, that is normal effects along with the disabling dyskinesia are shown, and sometimes loss of effect of levodopa is shown. This is the on off phenomenon, which is sudden and unpredictable fluctuations. Okay, and this can be prevented by COMT inhibitors, and also wearing off phenomenon can be reduced by COMT inhibitors. And for that we can also use sustained release formulations of levodopa and carbidopa we can use for wearing off phenomenon. And next group of drugs are dopamine agonists. Okay, first we discussed about dopamine precursor, which is levodopa along with the carbidopa. And next is dopamine agonist. Okay, dopamine agonists, and they directly stimulate the T2 receptors and have longer duration of action than levodopa. Okay, levodopa has half-life of about 1 to 2 hours only. They have short duration, but they have longer duration than levodopa, and used in early mild Parkinson's disease in young patients. In order to reduce the adverse effect of levodopa, so we can use in young patients, we can use these dopamine agonists for mild cases. Okay, and the drugs include bromocriptine, pramipexole, ropinirole, rotigotine, and apomorphine. And bromocriptine is the ergot derivative. It is only ergot derivative, and rotigotine can be used as a transdermal patch, and apomorphine is used as a rescue therapy. And this ropinirole and Roticotin, they can be used as monotherapy in mild Parkinsonism or in combination with the levodopa and carbidopa, and bromocriptine can also be used. And the dyskinesia and fluctuation are less shown with these drugs than the levodopa. Okay, so bromocriptine is actually a D2 agonist, and it also has partial D1 agonism. Okay, and these are D2 agonists. And pramipexole also has more selectivity for D3 receptor. Okay, these are the things you have to remember. And then the adverse effects include what we told already in levodopa: nausea, vomiting, hypertension, hallucination, insomnia, sleep attacks. Then impulse control disorders. Okay, they are unable to control their impulses, that can lead to hypersexuality and all. Then but the GI symptoms like nausea and vomiting are lower for ropinirole and pramipexole as compared to the bromocriptine. Okay, next group of drugs are monoamine oxidase inhibitors. They inhibit the breakdown of dopamine in brain and decreases the dopamine level in the brain, and they increases synaptic dopamine level, and they can be used in mild early disease and also used as an add-on with levodopa. The drugs include Selegiline, Rasagiline, and also one drug safinamide. Okay, safinamide, Selegiline, Rasagiline, and safinamide. Okay, SRS, Selegiline, Rasagiline, and safinamide. The adverse effects include insomnia, and there is a risk for serotonin syndrome with SSRIs. Okay, and these drugs are administered orally. And they do not, the Selegiline and Rasagiline, they do not inhibit the monoamine oxidase in the periphery. So they have a neuroprotective role. They inhibit monoamine oxidase only in the brain. Okay, and thus they prevent the progression of the disease. They does not prevent, they slows down the progression of disease. And more potent is the Rasagiline. Okay, Rasagiline is more potent than Selegiline. And do you know which are the metabolites of Selegiline? You have heard about it. Those are amphetamine and methamphetamine. Okay, so these are the metabolites of Selegiline. So they can lead to insomnia, anxiety, and nausea and vomiting. And next group of drugs are COMT inhibitors. So COMT inhibitors are tolcapone, entacapone, and also opicapone. On this, entacapone only acts peripherally and tolcapone acts centrally and peripherally. They inhibit the peripheral conversion of levodopa to 3-O-methyl dopa. And COMT full form is catechol O-methyl transferase inhibitor, and they increases the duration of levodopa and can be used in wearing of phenomenon and on-and off phenomenon. Then adverse effects include diarrhea, orange discoloration of urine, and tolcapone can causes hepatotoxicity. Okay, tolcapone can cause hepatotoxicity, but it is not seen with the entacapone. So tolcapone is not preferred in patients with the chronic liver disease or any other liver disease. It's not preferred, tolcapone. And next group of drugs are Amantadine. Those are NMDA receptor antagonist, and they also increases the dopamine release and blocks NMDA release receptors, and also so this decreases the glutamate transmission. It is usually combined with the levodopa, and it can be used in mild Parkinson's disease and also levodopa induced dyskinesia. We can use this Amantadine. Okay, next, and the adverse effects are livedo reticularis, which are the dark pigmentations in skin and angle edema and confusion. Okay, you can remember it as LAMAC. Livedo reticularis, angle edema, Amantadine, and confusion. These are the main side effects, and can also cause other side effects like hypotension, hallucination, nausea, vomiting, etc. And next group of drugs are anticholinergics. Okay, centrally acting anticholinergics, which are the benzhexol, benztropine, then bipyridine, and also with the additional antihistamines with the additional anticholinergic activity are promethazine, okay, and diphenhydramine. And these are centrally acting, so they does not have peripheral anticholinergic activity. So anticholinergics, they block muscarinic receptors in striatum and restore the dopamine acetylcholine balance. So useful in tremor predominant Parkinsonism. Okay, I already told that tremor in Parkinson's is due to relative increase in acetylcholine level. So anticholinergic can be useful in tremor-induced Parkinson, tremor predominant Parkinson's. So some are trihexyphenidyl or benzhexol, then benztropine and bipyridine. Then it can cause anticholinergic side effects like dry mouth, blurred vision, urinary retention, confusion. Okay, these are actually less because these are central anticholinergics. Then other anticholinergics are with the less antihistamine activities are promethazine and diphenhydramine. Now, so if a patient with less than 60 years comes to you, so you can start with dopamine agonist, okay, like Bromocriptine, Pramipexole, and also along with the monoamine oxidase inhibitor. You can use this, and if a patient comes to you whose age is above 60 years, you can start with the Levodopa and Carbidopa. Actually, Levodopa is less preferred in young people and in patients. And for the management of wearing of phenomenon, you can add COMT inhibitors or monoamine oxidase inhibitor, and apomorphine is used as a rescue therapy. And for drug-induced Parkinsonism, we can use drug-induced Parkinsonism means these are induced by drugs, mainly antipsychotics, which are D2 blockers. So for that, we can treat it by stopping the offending drug, and antipsychotics include haloperidol, chlorpromazine, etc. And you can use anticholinergics or amantadine. Anticholinergics like benzhexol, benztropine you can use, but do not use levodopa. And so this is summary. Levodopa is the most effective drug but causes dyskinesia, and dopamine agonists are good in younger patients with mild Parkinson's disease, but impulse disorders are seen, impulse control disorders. And monoamine oxidase are used in mild diseases, and the side effects mainly include insomnia. I told you about Selegiline, metabolite is amphetamine, okay, so that can cause insomnia. And COMT inhibitors can be used in wearing of phenomenon. Monoamine oxidase inhibitors can also be used, and they causes diarrhea. And anticholinergics can be used in tremor predominant Parkinson's, but they are less preferred in elderly anticholinergics because they causes cognitive decline, okay, so anticholinergics are less preferred.